Hello friends, today we are going to discuss about non-convulsive status epilepticus. So non-convulsive status epilepticus is common in patients with a coma with the prevalence between 5% and 48%. So non-convulsive status epilepticus is the electroclinical state associated with altered mental status but lacking convulsive motor activity. It is difficult to diagnose in the obtunded and the comatose patient. Such a patient have often other serious medical condition and the diagnosis of non-convulsive status epilepticus is frequently delayed in this patient. So diagnosing non-convulsive status epilepticus demands high degree of clinical suspicion and for the reason likely remains underdiagnosed. So we'll understand what is coma. Coma is the disorder of the consciousness because of the damage to the diffused bilateral cerebral hemisphere, cortex, and ascending reticular activating system. The neural network starts from the dorsal part of the upper pons, continues in the mesencephalon, connects to the thalamus, and diffuses widely from there to the both hemispheres. In addition, ascending reticular activation system is associated with some nuclei in the pons and mesencephalon, the posterior hypothalamus, and the basal forebrain. So communication in this network is established through the neurotransmitters such as acetylcholine, noradrenaline, serotonin, and dopamine. So the structural and the biochemical damage and the disruption of this neural network may cause unconsciousness. The most severe picture in the spectrum of consciousness disorder is coma. In comatose patient, alertness and the awareness are completely lost. Many causes of both intracranial and systemic origin can cause coma. For this purpose, patient should be systematically approached and possible cause of mechanism should be considered in 5 major categories. So one is unilateral hemispheric mass lesion compressing diencephalon and brainstem. Then bilateral hemispheric lesion affecting reticular formation and the thalamocortical cycle fibers at thalamus level. Then infratemporal lesion that compress or damage the reticular formation in the brain system. Then diffuse lesion affecting the physiological function of the brain and the psychiatric condition mimicking the coma. About non-convulsive status epilepticus, it has high morbidity and mortality, and it is a treatable disorder when diagnosed properly. Non-convulsive status epilepticus has special symptoms such as unexplained confusion or coma or vegetative status and aura, which can distinguish from the normal condition. So non-convulsive status epilepticus is the continuous seizure activity with the minimum duration of 10 to 30 minutes on the EEG. Previous studies used different EEG criteria to identify non-convulsive status epilepticus patients, and the prevalence of non-convulsive status epilepticus ranges from 5% to 48%, and actual prevalence of non-convulsive status epilepticus is still unknown. The new ILAE classification is based on 4 axes, and one being semiology. Axis 2 is etiology, axis 3 is EEG, axis 4 is the age of the patient. This concept takes into account the requirement of classification, supporting the clinical diagnosis and enabling the research through standardization while ensuring the individualized treatment concept for the patient. So we'll see what is the classification of non-convulsive status epilepticus. So first one is non-convulsive status epilepticus with coma. So then second one is non-convulsive status epilepticus without coma. It includes generalized typical absence status, atypical absence status, and myoclonical absence status. Then focal without impairment of consciousness, aura continua with autonomic, sensory, visual, olfactory, gustatory, emotional, psychic, experiential, or auditory symptom. Then aphasic status with impaired consciousness and unknown whether focal or generalized. And then autonomic status epilepticus. Clinical evidence may vary greatly in negative and positive symptom can be evaluated into 2 groups. Negative symptoms are anorexia, aphasia, mutism, amnesia, catatonia, coma, lethargy, and negative symptoms are agitation, aggression, automatism, twinkle, crying, delirium, echolalia, laughing, nausea, vomiting, nystagmus, eye deviation, preservation, anxiety, and psychosis. Non-convulsive status epilepticus is the treatable neurological emergency when it is diagnosed properly. So diagnostic criteria depend on clinical status, EEG finding, and response to the treatment. During initial evaluation, EEG recording is crucial for patients with acute confusion. Although the etiologies of non-convulsive status epilepticus and coma intersect, non-convulsive status epilepticus is the distinct clinical picture and electroclinical condition without convulsive motor activity. Diagnosis is difficult in the comatose patient. So the diagnosis of non-convulsive status epilepticus is often delayed in those patients. Clinically, high degree of suspicion is required for the diagnosis. Inter Ictal interictal discrimination of activity on the EEG is difficult despite newly defined criteria, and these criteria have practical application difficulties. Another important issue is how aggressive treatment of non-convulsive status epilepticus in comatose patients should be, because positive or negative effect of non-convulsive status epilepticus treatment on the prognosis of those patients is not well known. A distinction should be made between the patient with coma and other severe disorder and those with really epileptic mechanism, and treatment should be decided accordingly. So specific EEG pattern are not seen in coma. So EEG pattern in comatose patient. Intermittent rhythmic delta activity. Among EEG finding in encephalopathy, intermittent rhythmic delta activity is considered to lie at milder end of spectrum of coma EEG pattern. So intermittent rhythmic delta activity may appear in patients who are awake or who are mildly lethargic or stuporous. So these patterns are not associated with deeply comatose state. It tends to occur in frontal region in the adult and in occipital region. Now, prolonged burst of slow wave activity. Prolonged burst of slow wave activity can occur in variety of etiologies in coma. They are most often diffuse but can also be lateralized without any spatiotemporal evaluation. Then stimulus-induced rhythmic periodic or ictal discharge. Stimulus-induced rhythmic periodic or ictal discharge are a relatively common phenomenon found in prolonged EEG monitoring that captures state changes and stimulation of comatose patients. Common causes include hypoxic injury, traumatic brain injury, hemorrhagic and toxic metabolic disturbance. Now, the generalized periodic and rhythmic discharge. Generalized periodic discharge with triphasic morphology have been associated with non-epileptic encephalopathy. So, this is a picture of showing regularized generalized spike and sharp wave activity. Now, the next EEG pattern is lateralized periodic discharge. Periodic lateralized epileptiform discharge are associated with obtundation in 95% of patients. Focal seizure, focal neurological sign may occur in 80%, and epilepsia partial continue in 30% of patients. So this is the EEG pattern of the patient, a 40-year-old female, mentally retarded, epileptic patient admitted to clinic with psychosis and diagnosed as limbic encephalopathy. This EEG pattern is showing lateralized periodic discharge left hemisphere, flat period with 1 to 2 seconds of duration. Then the next one is triphasic wave. They are periodic and generalized, typically frontal predominant and not always epileptiform in appearance. This pattern can appear in any toxic metabolic and structural encephalopathy, although the early descriptions are associated with its present to hepatic encephalopathy. So, this is the EEG pattern showing triphasic appearance. Characterized by periods of low or absent. This pattern can be physiologic, for instance, during development, or pathologic, for example, in almost half of the comatose patient with first 48 hours after cardiac arrest. The burst suppression pattern can also found in various etiologies and during hypothermia. Etiologies like structural, toxic, and metabolic changes and during hypothermia. So this is the EEG pattern showing the burst of mixed frequencies input a theta coma pattern. Alpha coma can also be seen in intoxication like barbiturates, benzodiazepine, anesthetic agent, and imipramine, brainstem lesion, locked-in syndrome, and hypoxic ischemic encephalopathy. Theta coma refers to the diffuse background activity of 4 to 7 Hz in coma. Theta coma pattern in patients with cortical dysfunction such as dementia and mild to moderate encephalopathy. Then spindle coma pattern. Spindle coma pattern in spindle, slow activity, and K complexes. They have been initially described in brain trauma but can be found also in with other etiology. The etiology of spindle coma may be traumatic brain injury, intracerebral hemorrhage, post-ictal stages, and intoxication. So this is the EEG wave with the spindle prominence in left fronto-central region. We can appreciate this EEG form is the showing the spindle-like structure. Then EEG criteria for the non-convulsive status epilepticus in comatose patient. Various EEG criteria have been used in previous studies to identify non-convulsive status epilepticus, yielding prevalence between 5% and 48%. But the true incidence of non-convulsive status epilepticus in coma is still not known. So non-convulsive status epilepticus is neurological emergency that is seen in wide spectrum of cases. Diagnosis cannot be made without EEG due to diversity of clinical picture and impaired consciousness due to underlying primary damage, especially in the intensive care patient. So in the London Innsbruck status epilepticus meeting, the previous terminology was reviewed and Salzburg criteria for diagnosis of non-convulsive status epilepticus is reported. In comatose patient, epileptiform discharges faster than 2.5 Hz and generalized periodic discharge, lateralized periodic discharge, and continuous 2 per second generalized periodic discharge with triphasic morphology of less than 2.5 Hz as well as rhythmic discharge faster than 0.5 also taken into consideration as non-convulsive status epilepticus if they responded to benzodiazepine treatment with improvement in EEG and mental status of the patient. Non-convulsive status epilepticus with coma can be accompanied by generalized epileptiform discharge and coma with lateralized epileptiform discharge. Now, etiological factor and EEG pattern found in coma, generalized epileptiform discharge, and lateralized epileptiform discharge are given. So, this is the without should be more than 2.5 Hz. Epileptiform discharge is less than 2.5 Hz or rhythmic delta or theta activity. And one of the following, that is EEG and clinical improvement after IV anti-epileptic drug or subtle clinical phenomenon or typical spatiotemporal evaluation. Patient with the known epileptic encephalopathy, there is increase in prominence and frequency when compared with baseline, with improvement of clinical and EEG feature with IV anti-epileptic drugs. If EEG improvement without clinical improvement or if fluctuation without definitive conversion, this should be considered possible non-convulsive status epilepticus. Increment onset or evolution in pattern or decrement terminology. Then coma with the generalized epileptiform discharge. The etiology is diffuse primary and secondary brain disturbances caused because of anoxic injury, toxic injury, metabolic, infectious, and degenerative pattern. Then space occupying lesion with brainstem compression. EEG pattern is continuous generalized spiking, periodic spiking, burst suppression pattern in the different variation. Then coma lateralized epileptiform discharge. It happens because of focal brain lesion. In rare cases, diffuse abnormalities. The EEG pattern is continuous focal spiking, then periodic lateralized epileptiform discharge, bilateral plate and unilateral burst suppression pattern and unilateral triphasic wave. Now, the suggested algorithm for treatment of non-convulsive status epilepticus. For initial 5 to 10 minutes, first line drugs are benzodiazepine. Preferred drug is lorazepam, that is 2 to 4 mg IV bolus. We can also give diazepam 10 mg IV bolus. Then in urgent control period, we can use the second line drug, that is phosphenotoin 15 to 20 mg per kg IV up to 100 to 150 mg per minute. Then phenytoin, that is 15 to 20 mg per kg IV up to 50 mg per. Then valproic acid 20 to 40 mg up to 5 mg per kg per minute. Levetiracetam is 1500 to 3000 mg IV over 15 to 20. And then lacosamide can also be given in the dose of 100 to 400 mg IV. In case of epilepticus, it will be if not already done. Continuous infusion of anti-epileptic in combination with ongoing bolus treatment. That is midazolam 0.2 mg per kg every 5 minutes until seizure stop, then 2 mg per minute. Propofol 1 to 2 mg per kg IV loading dose followed by 1.8 to 1.12 mg per kg per hour of continuous infusion. Then phenobarbital 5 mg per kg of loading dose every 5 minutes until seizure stop. Then 1 to 10 mg per kg per hour for at less than 50 mg per minute. Then ketamine 1 to 1.5 mg per kg IV every 5 minutes, maximum 4.5 mg per kg, followed by 1.2 to 7.5 continuous infusion. Then in super refractory status epilepticus, we can give the rescue therapy, that is ketamine infusion, inhaled anesthetic like isoflurane, serotogenic diet, and we can go for surgery. Thank you, friends.